Cirrhosis and its complications. Histopathologically, cirrhosis, whatever the cause, has an architectural distortion and formation of regenerative nodules that happens inside the liver. There is decrease in liver mass, decrease in its function, and alteration of blood flow. You will find complications of cirrhosis because of altered blood flow, which you will appreciate more when you are already practicing. When it comes to cirrhosis, there is an activation of hepatic stellate cells that increases collagen and extracellular matrix component. Here on the left side is a pathological liver, while on the caricature on the right shows you normal liver on the left lower and what happens to the liver when you have fatty components, production of scar tissue, and eventually regenerative nodules. The causes of cirrhosis are varied. It may start from alcohol when you are chronically taking alcohol, when you have chronic viral hepatitis, also if you have autoimmune diseases, what comes with it is autoimmune hepatitis. You may also have non-alcoholic steatohepatitis or your NASH. If you have biliary problems, you will develop biliary cirrhosis. If you have cardiac problems, you may develop cardiac cirrhosis. And you have your metabolic diseases that are inherited. When it comes to alcoholic cirrhosis, you have a model from fatty liver to hepatitis to cirrhosis. This is secondary to excessive chronic alcohol use. You will be predisposed, if you are a male, you will be predisposed to developing alcoholic cirrhosis when you take in 60 to 80 grams of alcohol per day, while if you're a female, is lesser from 20 to 40 grams. Alcohol is a direct hepatotoxin, unlike the viral hepatitis. This produces fibrosis in the absence of inflammation because of the direct toxin that alcohol causes inside the hepatocytes. Fibrosis can be centrilobular, pericellular, or periportal. If you have less than 3 millimeter regenerative nodules present, then it is called micronodular. When it is more than 3 millimeters, it is called macronodular. When you see patients in the clinic, they may present vague right upper quadrant pain. They may have fever, nausea, vomiting, and the constitutional symptoms. It depends on the degree of the cirrhosis. You may find edema, ascites, bleeding, jaundice, and encephalopathy. Upon examination, you already discussed the physical examination of the abdomen. You may find organomegaly, such as hepatic enlargement, or you may find your trough space obliterated, pointing to spleen enlargement. You may have discoloration of your sclera, palmar erythema, spider angioma, and so on and so forth. These are the clinical features of a cirrhotic patient that may be on his or her last few days when it comes to life expectancy. On your left is a typical palmar erythema of a cirrhotic person, regardless of the cause. Cirrhosis that comes from cardiac problem or viral hepatitis may present as such palmar erythema and spider angioma upon inspection and physical examination. Here is a cartographic sketch. You have your ascites, you have your angioma, discoloration or jaundice, dilatation of the vessels, and even confusion that pertains to hepatic encephalopathy. On your right is an actual patient, a picture of the patient who has cirrhosis. Upon examination, when you ordered for laboratory, you may find anemia secondary to chronic blood loss or even hypersplenism. Nutritional is included in this uh, in the cause of anemia simply because if you have a patient with ascites, he or she cannot eat anymore. Therefore, the nutritional intake is affected. You will have thrombocytopenia, elevation of your bilirubin, prolongation of prothrombin time, elevation of transaminases. But if the liver cells are already destroyed, elevation may not be that evident. Hypoalbuminemia may also be present because of the synthetic function of the liver is now affected and increased globulin. In diagnosing this kind of patients who will come into you, sometimes it will be a referral from your co-doctors who has the abnormal laboratory features that we mentioned. Upon seeing the patient in your clinic, you again dig on the history, you examine the patient, and perhaps imaging may help. If you dig in the history and the patient continues to drink, you have to advise them to abstain from taking in alcohol because the survival rate is affected by the alcohol intake. That means if the patient continues to drink, the life expectancy of that patient is drastically diminished. On the other hand, if you tell the patient to stop taking in alcohol and he followed your advice, then the survival will improve dramatically. Therefore, abstinence is the cornerstone of treatment. You have to adequately give patients with high nutritional value food and close follow-up and the management of complications is very, very important. Sometimes you will find doctors that uses glucocorticoids and pentoxifylline. These are some of the drugs available nowadays that improves survival, especially in patients with severe alcoholic hepatitis, while patients with previous hepatitis a viral hepatitis infection and you see patients with cirrhosis, it is termed as post-hepatic cirrhosis. Of the viral hepatitis, hepatitis B and C are the two viruses that usually cause post-hepatic cirrhosis. The progression to cirrhosis is characterized by portal and bridging fibrosis and formation of nodularities. If you will remember, there are micronodules and macronodules. So you have to note of the sizes of nodules although you cannot see this in your physical examination, it may be important to note when you take your examination. Again, post-hepatic cirrhosis, the inflammatory infiltrates are found in the portal areas with concomitant interface hepatitis. As we have mentioned, hepatitis B and hepatitis C are among those patients that will later on will develop cirrhosis. Upon biopsy, you may find ground glass hepatocytes. We already discussed this. All of the patients with cirrhosis might come in with the same features, whether it be alcoholic or post-hepatic. So the usual clinical features are the constitutional signs and symptoms like fatigue, malaise, vague right upper quadrant pain, and laboratory abnormalities that we have already mentioned, like the prolongation of the protime, the derangement of the synthetic function of the liver, like decrease in albumin, or you may find the patients already bleeding secondary to thrombocytopenia. The diagnosis requires, this is post-hepatic cirrhosis, you may require the determination of HCV-RNA to, to note if this is from hepatitis C or the HBV DNA levels. The HCV RNA is for hepatitis C because hepatitis C is an RNA virus in contrast to HBV, which is the only DNA virus among the viral hepatitis. The treatment is geared towards the management of complications since patient will come in because of complications. You seldom see patients with cirrhosis who doesn't have any complication. Some of your patients will come into your clinic or into the hospital secondary to bleeding, vomiting of blood, or melena, or even hematochezia, patients with ascites that will develop eventually difficulty of breathing, and sometimes patient will come in due to encephalopathy. You have to remember also that encephalopathy has several stages, but at this point, it is nice to know that sometimes patients with cirrhosis will come in only with problems or difficulty in falling asleep. So that may be a sign of early encephalopathy. So how do we treat? In chronic hepatitis B, it is beneficial to give antiviral therapy. In antiviral therapy, there are several medications available. and some of which are oral, some of which are injectable like the interferon. Bear in mind, if you have chronic Hepa B and the patient is cirrhotic already, interferon may not be beneficial to those patients. So you have to give the patient nucleoside analog as a form of treatment. While in chronic hepatitis C, this is more complicated to treat because of the dose limiting cytopenias, like for example, decrease in your platelets, decrease in your WBC, or even your red blood cell. There is also what we call autoimmune hepatitis, like we have mentioned in the table previously. And if you're going to do liver biopsy in this type of patients, you will not see any, or if at all, there will be little inflammation. To diagnose this, you have to do your anti-nuclear antibody testing and anti-smooth muscle antibody. If they are positive and you have a we have patients with cirrhosis, then maybe you are dealing with autoimmune hepatitis. As opposed to non-alcoholic fatty liver disease, in the US, where the very first studies came from, there are originally termed as cryptogenic cirrhosis. They haven't formed the nomenclature of the non-alcoholic fatty liver diseases because originally most of the patients being diagnosed with cirrhosis were alcoholic during that time. And if they don't have any significant alcohol intake and the patient presented with cirrhosis, then they term them as cryptogenic. But the newer nomenclature, because of the involvement of the metabolic panels, like for example, elevation of your fasting blood sugar, elevation of your cholesterol. So the metabolic panel are already dysfunctional. So the more appropriate term now would be metabolic dysfunction associated fatty liver disease, or your MAFLD. Also, you have biliary cirrhosis as cause of, rather, you have bile cholestatic liver disease as cause of cirrhosis. And bile may be intrahepatic or extrahepatic. When you say extrahepatic, there may be obstruction that will improve if you subject your patient in surgical or endoscopic intervention. You have to decompress the site wherein there is obstruction. While intrahepatic, the cholestatic process will not improve with such intervention and may require different approach. With regard to the complications, we have already mentioned that you may find patients with bleeding, maybe secondary to gastroesophageal varices, secondary to hypersplenism, and eventually there will be production of fluids that will accumulate in the intra-abdominal area. It is termed as ascites. Other complications we have already mentioned, like hepatic encephalopathy. You have different stages. You may find spontaneous bacterial peritonitis, wherein at the setting of cirrhosis and ascites, patient will develop fever And when you do your paracentesis, the PMNs are elevated, more than 250. And also, when the patient's initial presentation is only ascites and normal creatinine, and the creatinine becomes elevated as the ascites worsens and the kidney function is already affected, you will see patients with hepatorenal syndrome. And worst of all, if the patient is an alcoholic and continually drinks alcohol, even if you tell the patient to stop, then the worst of the complications termed as hepatocellular carcinoma may ensue. In portal hypertension, there is an elevation of your hepatic venous pressure gradient, more than 5 millimeter mercury. If you have elevation of pressure, the fluid will leak out and becomes ascites. The fluid will cause a backflow of blood into the portal circulation. Varices will develop in the esophagus and the stomach area, wherein patient will be predisposed to upper GI bleeding. Hypersplenism is also an effect of the increased pressure of the hepatic venous area. If you develop variceal hemorrhage, it can be secondary to esophageal varices or gastric varices. If the patient doesn't present with upper GI bleeding, it is prudent to advise the patient to undergo screening endoscopy because 1/3 of patients with cirrhosis will develop varices and eventually a complications that may require blood transfusion later on. If you advise your patient in the screening endoscopy, you should tell the patient that he or she may undergo a primary prophylaxis. If you subject your patient to endoscopy and you see varices as you see in the third picture on your right side, then you have to place a rubber band. And you give a non-selective beta blockers like your propranolol as a primary prophylaxis in the prevention of bleeding varices. Varices may be present in the esophagus and also the stomach. Prophylaxis in the stomach, since the stomach is a very mobile organ, then variceal rubber band ligation may not be as effective as it is in the esophageal area. You may need to inject tissue glue or the histoacryl in the prevention of further or future bleeding. And repeated ligation or histoacryl uh, treatment of the varices may be done until all the varices are obliterated, therefore preventing future bleeding. If your patient comes in already bleeding, especially if it is profuse, you have to do the ABCs of resuscitation. You have to assess your patient because of the hemodynamic status. the breathing, and the circulation. Fluid replacement of your crystalloid can be started as soon as the patient's blood pressure drops or the heart rate is already increased. Vasoconstrictors may be given, also tamponade, RBL if the patient is already stable, or surgical or surgery in the form of transjugular intrahepatic portosystemic shunt. If you control the bleeding, you look for other abnormalities. Like for example, if you do ultrasound and you saw or if you see the patients with hypersplenism, then splenomegaly is already present. This is a common sight in patients with ascites, wherein there is congestion in the spleen brought about by the portal hypertension. So patients will come in due to left upper quadrant pain. CBC might reveal thrombocytopenia, and physical examination will reveal obliteration of strobe space secondary to splenomegaly. And hypersplenism with thrombocytopenia is usually the first indication of portal hypertension. We already mentioned that if there's increase in HPG, hepatic portosystemic gradient, ascites will form. This is due to accumulation of fluid in the peritoneal cavity. And it happens because there is an increased portal pressure. So therefore, the collaterals will open secondary to nitric oxide. And there will be an increased portal inflow. And this vasodilation and increased portal inflow will lead to increased production of the splanchnic nerve, a splanchnic lymph, and the fluid that is formed is what we call ascites. What happens here, there will be sodium retention, hyperaldosteronism, and the concomitant hypoalbuminemia secondary to abnormal production of albumin by the liver will ensue. So how does the patient present to your clinic? There will be an increased abdominal girth. You will see edema. By the way, if you already passed your physical examination, when you say edema, you have to note if this is pitting or non-pitting because ascites is not always secondary to liver diseases. You may find ascites also in patients with heart problem. And if you have difficulty of breathing or shortness of breath, you have your weakness and muscle wasting, then you have to have a high index of suspicion that you are dealing with ascites. When you do your physical examination, the usual puddle sign, shifting dullness, positive fluid wave, etc., you have to take note of it. And to diagnose, as we have mentioned, the bulging flanks, shifting dullness, and if you do ultrasound, there will be presence of fluid. Then, when we do manage this, we have to do diagnostic paracentesis to note if the patient's ascites is secondary to hepatic problems or other problems. In so doing, There are several tests like your SAAG or your serum ascites albumin gradient, wherein more than 1.1 gram per DL, it points to portal hypertension. This is usually being asked in the examination. Please take note of this. In contrast to SAAG less than 1.1, then the presence of ascites may be secondary to an infectious process or maybe a malignant transformation. And we have already mentioned if you have more than 250 PMNs or polymorphonuclear cells, then you have to consider the presence of bacterial peritonitis. If your bacterial peritonitis is present, you may opt to give antibiotics. Together with antibiotics, if you are entertaining bacterial peritonitis, the treatment is sodium restriction and giving of diuretics in the form of spironolactone, furosemide, and even repeat paracentesis if the patient has refractory ascites. The more invasive procedures like surgical, your tips, and your liver transplantation may be an option. Going back to SBP, your PMNs is more than 250, and when you did your paracentesis, then there is a spontaneous infection due to bacterial translocation. You have your normal flora, but sometimes it goes out of the lymph nodes, creating bacteremia, and eventually the bacterial will go to the acidic fluid, causing elevation of WBC, will cause infection secondary to your E. coli and some gram-positive bacteria. Again, the PMNs more than 250 per microliter. How do we treat? We already mentioned that when you have bacterial peritonitis, you have to give antibiotics. Otherwise, the patient will be toxic in the next few days. So, what do we give? The empiric treatment after noting that the PMNs is elevated. So, you have to give the third generation cefotaxime, 2 grams IV every 8 hours. You have to do skin test on this. Also, if there is fever, there is tenderness, there is already change in mental status, meaning your patient has hepatic encephalopathy, then the empiric therapy is indicated until after the result of paracentesis comes in and you have already identified what type of organism infects the fluid, then you may shift to the antibiotic that is covering what is present in the fluid. Another complication we have mentioned is the hepatorenal syndrome. In this type of complication, initially there is no abnormality in the kidneys. The function prior to hospitalization, the kidney functions are normal, and as the ascites amount or the acidic fluid amount increases, there is a concomitant increase in the creatinine level. Therefore, the, the kidneys is now affected. How do we treat? We treat by giving medications like midodrine, octreotide, together with intravenous albumin, because we have already mentioned that the albumin is the range, the synthetic function of the liver is the range when you have your ascites. The prognosis of is very poor even if you give the best medical treatment available. Chances are your patients will require liver transplantation to increase the life expectancy. Another complication is hepatic encephalopathy. In this, there is an alteration in the mental status and cognitive function in the presence of liver failure. You have your deranged blood chemistry, blood. You have your deranged blood tests like low albumin, thrombocytopenia, prolongation of time. Then there is this disturbance of sleep pattern. Your patient, the relatives of the patient will tell you patient is sleeping in daytime and awake in nighttime, which they don't usually observe. Then the patient might be having hepatic encephalopathy. What happens here is the gut-derived neurotoxins are have already passed through the liver because the liver cannot remove it. So therefore, there will be accumulation of ammonia, mercaptans, and false neurotransmitters. This will result in the changes in mental status that may occur in weeks to months. And if the encephalopathy is severe, then cerebral edema may occur. This is the swelling of the gray matter with cerebral herniation. And when it does happen, then the patient might come in the emergency room more toxic. So what will be the things to look for and things to prevent when you see patients with ascites, liver cirrhosis, and you are entertaining that the patient might have hepatic encephalopathy later on? You have to watch out for some precipitating events like infection, increase, rather electrolyte abnormalities, GI bleeding, dehydration, and unnecessary increase in dietary protein load. Now, you know for a fact that patient requires dietary protein to increase the albumin. So therefore, you have to give your as a supplement, since you cannot take this, the dietary protein cannot be taken from meat intake, so you have to give branch chain amino acid. Also, as part of treatment is to treat the precipitating factors like your infection, UTI, amoebiasis, pneumonia. These are infection. Some of the examples of infections that may precipitate hepatic encephalopathy. You have also to give non-absorbable disaccharides. The goal is for the patient to have soft stools so that the nitrogenous products like the ammonia can be removed by giving lactulose that will acidify the colon and leading to catharsis. You may also give non-absorbable antibiotics like your metronidazole, neomycin, and rifaximin when the patient, or rather when you are entertaining uh, ongoing infection. and zinc supplementation can be given. So the other complications, if the patient cannot take in food anymore, since the patient is in a catabolic state, then malnutrition will set in. So if this happens, then you have to protect, or rather prevent malnutrition by giving, as we have mentioned, branch chain amino acids. Because amino acids, you know this from your biochem, amino acids are the building blocks of protein. And coagulopathy will set in. This is due to the decreased synthesis of the liver of the clotting factors and may be secondary to hypersplenism. Other complications are bone disease, like the patients will come in due to osteoporosis. This is secondary to malabsorption of vitamin D and decreased calcium ingestion. Secondary again because the patient has too many problems inside, especially ascites. There will be a decrease in food intake and calcium intake. Therefore, it may lead to osteoporosis. Other hematologic abnormalities like anemia and microcytosis can be found in patients with cirrhosis. Upon knowing this, you treat your patients holistically. So you have to include the relatives, because the relatives will prepare, will give the nutrition, will prepare the food that the patient is going to take in, because the patient at this point is incapable of taking care of himself or herself. You have to note that there will be some patients will require additional help, like a private duty nurse, because of they cannot anymore move, and patients might, if the patient continues to drink, might develop hepatocellular carcinoma later on. So upon knowing this, as a doctor, it is your duty now to make sure that the patients with liver problems will be taken care of in the best possible care possible. With that, I thank you for your kind attention.